Dr. Tanya, you can start. Hello.
Okay, sir. Assalamu alaikum. Good evening, everyone, and welcome to today's webinar. Our topic is about clinical outcomes and emerging trends in regenerative endodontics. My name is Sania Arif, and I will be your host for today's session. We are delighted to have participants joining us from across the country and beyond for what promises to be highly informative and clinically relevant discussion in one of the most evolving areas in modern endodontics. Before we begin we just a few housekeeping points. This session will be approximately 40 to 50 minutes long. Kindly keep your microphones muted during the presentation. You must post your question in the chat box at any time. We will address them during the Q&A session at the end. This session is being recorded and the recording link will be shared with all the registered participants afterward. Thank you for joining us today. It gives me great pleasure to introduce our distinguished speaker for today, Dr. Farrukh. Dr. Farrukh is highly respected clinician and researcher holding qualification in BDS RDS and is the author of 20 research publications in the field. He also the founder of Pride and Experience Dentistry, where he has successfully combined evidence-based practice with patient-centered care. Today, Dr. Farrukh will be sharing his expertise on regenerative endodontic procedure, focusing on biological concept, current clinical protocols, case selection, and how regenerative approaches are transforming the future of endodontic treatment. So, without further ado, please join me in warmly welcoming Dr. Farrukh. Dr. Farrukh, the virtual floor is yours.
Thank you very much for a very great introduction, Dr. Tanya. Assalamu alaikum, everyone. I hope you all are doing great. Uh, it's very great that today we are closing the 2025, the last day of 2025 this year, with also informative sessions. And today is basically the last webinar of the new series that we have started earlier in this month, Regenerative Endodontic. The topic of which is today is basically clinical outcomes and emerging trends in regenerative endodontics. So let's, without any further delay, start this webinar. Okay, so this is a little bit introduction about me as Dr. Tanya introduced me. My name is Dr. Mohammad Farrukh, and I'm graduate of Margaret Institute of Health Sciences. I did my graduation in 2021. I'm founder of Pride as well as Experience Industry. Uh, Alhamdulillah, Summa Alhamdulillah. I have 25 research publications in my name, out of which 3 are published internationally. Uh, I am currently running my own clinical practice with the name of Dr. Farrukh Dental Clinic, and I also had the privilege of getting distinction in my undergraduate in the subject of oral medicine, UHS. Okay, so today's webinar is a little bit very much short. There will no discussion a lot, but we will be discussing these points. We will really understand the clinical outcomes of regenerative procedures. We will identify the success and failure factors of regenerative endodontic procedures, and we will evaluate the long-term prognosis regarding using use of regenerative endodontic procedures. Okay, so this will be our main focus for the day, and we will discuss the research and innovation, what the research and new innovations have to say regarding the regenerative endodontic procedures. Okay, so without any ado delay, let's start. Okay, so why regenerative endodontics? Why there is a need of regenerative endodontics? Uh, as you all know that traditionally what we used to do, we used to do root canal treatment whenever a pulp die. So whenever a pulp die in any immature teeth, the tooth which with an open apex, like the tooth which is erupted into the oral cavity, but the apex has not been closed yet. What we used to do is we used to close it with apexification or a long term by placing calcium hydroxide in it. Okay, so these methods, what they do, they do close the apex, but they leave the tooth weak and they make the it prone to fracture. Okay, So in the long run, it was not a very good method. But when the time regenerative endodontic has been introduced, what it is being offering, it being offering a biological solution where we try to restore the vitality and also allow the root to continue developing. This is especially beneficial for the children and young patients. This regenerative endodontics. Okay, so what it does, it restores the pulp vital tissues, it continues the root tooth development, it improves the tooth strength and longevity that we need in the long run. Unlike the conventional root canal, the goal is healing and regeneration, not just disinfection and filing. You guys remember this thing in the root canal. What we do is we remove the immature pulp by the filing and disinfecting it and then obturate it. But in this case, what we do is we remove the necrotic pulp, but we provoke the bleeding, and we let which leads to the formation of vitality, regrow of the vitality of the tooth. Okay, okay, this picture can explain you better. Okay, what does we do in regenerative endodontic procedure? In the first appointment, the patient is being called. We do a excess opening as we do in root canal. Okay, then we take the working length determination, and then we prepare a canal. We remove the necrotic pulp, and then we irrigate it with the help of syringe needle, and then we dry the canal with the paper point, uh, and then place a temporary seal, a medicament. Okay, up to the cement on emulsion. So this is our first appointment in the root and regenerative endodontic procedure. Then we call for the second appointment to the patient. In the second appointment, what we do is, sorry, we remove the medicament that we have played earlier. Then we again dry the canal with the paper point. Uh, then we induce bleeding here. What we are doing, this is a very much important point. We are making our file go 2 millimeter ahead of the apex point, the that was which was earlier the apex of the tooth, and what it will lead to, it will lead to the bleeding induction in it. Okay, which we need. Why? Because it ultimately led to the formation of blood clot formation, which will also act as a scaffold and led to the formation of led to the signaling molecules and growth factor to be there, and which will ultimately regrow the vitality of the tooth. Okay, so in this way, you can see in the last picture that we have restored the vitality of tooth and the pulp is being back. Okay, so about basically the triad, regenerative triad of you all remember this, that we have discussed in the first and second webinar as well. Successful regeneration requires the three key elements. The three key elements need to be present. Then you will get a great regeneration in it. Okay? The first thing is basically stem cells, the source of which can be there are many sources, but the best source is basically apical from papilla. Okay, then which is responsible for the tissue regeneration. Then we have scaffold. You need to remember these three. Yes, okay. The second has basically it could be a blood clot that we that I showed you in the last picture, which will it is the most common. Then it could be PRP, PRF, and it provides a framework for the cell growth. And then we have signaling molecules or growth factors. It is also necessary because it is released from dentine and blood, and it promotes cell differentiation and healing. Okay, so this is a very much important. For example, a necrotic immature tooth can regain vitality if all these three components are present. So in this, if you have these three elements, then you can grow the pulp back into the tooth, which is basically which was earlier which was necrotic, non-vital pulp. Okay, okay. What is the success criteria in regenerative endodontics? So success criteria in regenerative endodontics, the most important are the stem cells that come from basically apical papilla, which we are saying that stem cells from apical papilla, SCAP, as I discussed previously. These cells can survive even when the pulp is necrotic. Okay, because you know that stem cells present in the apical portion, they do survive. Okay, they have the ability to differentiate into the pulp-like tissues and odontoblasts-like cells. That's why we avoid aggressive instrumentation to protect these cells. Whenever we are doing the first step of the procedure, we do avoid aggressive instrumentation because we need to protect these cells. Okay, so what are the primary outcomes? Primary outcomes are basically the resolution of pain. The pain is, there is no pain at all. Healing of periapical lesion, if there is any, no swelling or sinus tract. This is a good thing. ठीक है. Secondary outcomes, what it does is it increases the root length that we need, because in the immature tooth, as you know, that root is not fully formed, and it leads to the formation of thickening of dentinal walls. This is the thing that we also want. We don't want our tooth to be prone to fracture or have a thin dentinal walls, and it leads to the apical closure that we also need. ठीक है. uh, Tertiary outcome, what it does it the main thing that it does it allows the return of the pulse sensibility. The patient can now feel again sensation of cold and heat or electric pulse testing taken in that tooth that was previously necrotic and non-vital due to the necrotic pulse. Acha, so okay, so the important point to be noted here is a tooth can be clinically successful even without a positive vitality test. Okay, can be successful even without a take it. Case example number one, we will be discussing a few examples here. A patient came with the age of 9-year-old. The tooth, we saw the it had immature maxillary central incisor. Okay, so what we did, that diagnosis was the diagnosis made was the tooth was pulp was necrosed, ठीक है, with apical periodontitis. So what treatment step we took? We did a minimal instrumentation. We did irrigation with the sodium hypochlorite. We placed calcium hydroxide medicament, and then in the second appointment, we induced the bleeding, and then we placed the mineral tri-aggregate coronal seal. So what happened, or what the outcome appeared after 12 months, after 1 year, complete healing of periapical lesion, the root length increased, okay, and dentine walls thickened. So in this scenario, the treatment regenerative endodontic procedure performed gave a full clinical success, 100% clinical success. So there's another example in which we will be discussing regarding the partial success. So when we are talking partial, what we did, occasion came, it had following findings: periapical healing achieved, no significant root length increase, no response to vitality test. There is still considered successful in outcomes. If a periapical healing also is achieved, then we can consider it also in the partial success. So what can be the common reason for the failure? The common reason for the failure can be these four: inadequate disinfection, residual bacteria inhibit stem cell survival. So if there is any bacteria left despite being doing disinfection, then it can kill the stem cells stem cell survival. Okay, so we need to have a cleaned canal. That's why we are disinfecting it first. Then improper case selection, close apex cases show limited success. Okay, so one thing that I need to you all to always always keep this thing in mind. Okay, why? Regenerative and endodontics is perfect. Yeah, is best for the cases in which the root is not completed yet. There is no formation of no completion of root formation yet in the between the ages of 9 to 11 years. Okay, so these cases are the best for doing regenerative endodontic procedure. If there is a tooth which is being erupted into the oral cavity but it has root fully formed, then in those cases it will not be very much effective. Excessive instrumentation, basically damages apical stem cells. As I told you, that we require apical stem cells, uh, and that we can that are all induced basically because of the bleeding, and when we move 2 millimeter. Prevent please of doing aggressive instrumentation. Okay, it will damage them. Coronal leakage. Poor sealing leads to the reinfection. Okay, so when you have placed the medicament and you didn't seal it coronally at that time in the first appointment and the second appointment as well, it can also lead to the reinfection as well. So it can lead to the ultimately lead to the failure of your procedure. So case example, there is example of case where a failure scenario: a tooth with immature mandibular molar issue. We had a mandibular molar, okay, which it was immature. The issue was basically there was a persistent sinus tract after root canal. Root canal was performed, but still there was sinus there. There was no resolution of this sinus tract. What could be the possible reason? Possible reason could include inadequate irrigation, poor coronal restoration, and patient non-compliance. So you in your terms, basically you might have not done very much good irrigation. There was no coronal seal achieved being in the restoration, and in the patient side, basically the patient was not very much compliant. So what are the management option for us? You guys can do the repetition of that regenerative procedure, and then do again apexification, also followed by a conventional root canal treatment. Take it. So what does the research says about regenerative endodontics procedure, your clinical outcomes, your survival rates, and failures point? Many of the systemic reviews shows 80 to 90% survival rate, a high periapical healing success in regenerative procedures, variable root maturation, factors improving prognosis, and it's very much important. Helpful in the younger patient, with a patient with wide open apex, short duration of infection, and proper coronal seal. The long-term studies suggest that 5 to 10 years shows that regenerative teeth are stronger than the apexified teeth. In which we used to basically fill the canals with calcium hydroxide and do apex excision, it is much better than that. Okay, this one. So what is current research updates giving us that we have achieved biomimetic scaffolds. The scaffolds basically that are just mimicking the original tissues. Synthetic, there are synthetic hydrogels available now. There are collagen matrices available now. In the platelet concentrates, we have PRF preferred over blood clot, and better growth release, better release are there. There are cell-based therapies which can do. We can do a stem cell transplantation experimental, and pulp tissue engineering as well, which is being very much done right now, as you might have heard on the rats in the labs as well. Bioactive materials, we have also new bioactive material, bioceramic seeders, and new MT alternatives. Right now, the scientists have lessened the use of calcium hydroxide and replaced to the now MTA. It's a much better biotic material. And AI and imaging, it also is also playing a role in it. CBCT based outcome prediction, we can also predict with the help of CBCT and AI assisted case selection. Okay, so what are the future directions regarding this? Two pulse lentine complex regeneration uh, can happen with this regenerative procedure. Personalized regenerative protocols can be followed, and regeneration in mature teeth as well. In the future, it will work when there will be such a done. Key points to remember: regenerative endodontics is biological healing, not just a procedure. Clinical success is not equal to vitality response. Okay. Um, Case selection and disinfection are critical. So this is a very much important one. Like case selection is the first thing, and then how much you have a good irrigation and disinfection. And emerging technologies are reshaping the future of endodontics. We are seeing with the help of AI. Okay, so take a home message for today is regenerative endodontics shifts our focus from saving the teeth to restoring the life within the teeth. Okay, so this was all about today's session. I hope it was fruitful and you guys got the concept of regenerative endodontics. Uh, and it was the last session of basically regenerative endodontics series as well. And the last webinar of 2025 for experienced industry as well. So if you have any questions, please feel free to uh, tell in the chat box. Thank you very much. Dr. Tanya, have you any question?
Thank you, Dr. Farrukh, for the truly enlightening and well-structured presentation. We
Welcome.
will now move on to the Q&A session.
Yes, please. If there are any questions, please feel tell us.
Okay, so there is no question at the moment. We will wait for 5 minutes, and if nothing comes in, we will conclude the session.
Okay, regarding the feedback form, if you have, please do share it.
Okay. So there is no question. Thank you once again, Dr. Farrukh, for sharing your valuable experience. And sincere thank you to all our participants for joining us. Before we conclude, a gentle reminder to please complete the feedback form that will appear shortly on your screen. Stay connected with us for upcoming sessions in this webinar series. Have a wonderful day.
Should I close the session, or there will be a sharing of a feedback form?
आई थिंक ग्रुप में सेंड कर देंगे, अभी तो नहीं है फीडबैक फॉर्म.
ओके, ठीक हो गया. ठीक है गाइस, ख्याल रखिएगा अपना. हैप्पी न्यू ईयर टू यू इन एडवांस. और इंशाल्लाह नेक्स्ट ईयर फिर आप लोगों के साथ मुलाकात होगी. ख्याल रखिएगा. अल्लाह हाफ़िज़.